Hello, in this video I'm going to discuss the importance of maternal mortality as a measure of how we care for pregnant women and mothers. Before we start talking about maternal mortality, I need to define some important terms. Maternal mortality is the phrase used to describe the death of a woman while she is pregnant, giving birth, or a pregnancy-related death after she gave birth. Some examples of how a woman might die are infection from the delivery process, bleeding out during delivery, known as hemorrhage, and death from a heart attack due to the stress pregnancy placed on the woman's heart. Generally, the period of pregnancy and 6 weeks after the pregnancy are considered when maternal mortality rates are determined. However, some researchers include the entire year after giving birth. In most cases, maternal death is a rare event. Because of this, it is measured in deaths per 100,000 births. This is called the maternal mortality rate, or MMR. This rate is used to assess how well a country or region cares for women giving birth. Maternal morbidity is also important in this discussion. This is an event that was serious enough that it could have led to death, but medical intervention prevented that. Events like this are heart failures during procedures, hemorrhage that was treated through blood transfusions, and emergency hysterectomies. These events are about 100 times as common as maternal death, so they are measured as an event per 10,000 hospital deliveries. Worldwide, there has been a lot of success with combating the death of mothers. Researchers at the Global Burden of Disease Maternal Mortality Collaborators have found that globally, maternal mortality has reduced by 30% between 1990 and 2015. Much of this progress came from preventing deaths from things like infection and hemorrhage in developing countries. However, these researchers also say that there is a lot of room for progress in global maternal mortality. The solutions they propose involve increasing the access the very poor have to health care while pregnant by increasing the number of doctor visits and hospital deliveries they receive. These researchers have found that 169 countries decreased their maternal mortality rate since 1990. However, 26 countries saw an increase. The United States is one of these. The United States is a very diverse country, with each state having different populations and public health policies. This leads to geographic differences in maternal mortality rates. Importantly, many states in the country have not acted to stop maternal death. This has resulted in rising maternal mortality. The CDC reports that the maternal mortality rate in 1987 was 7.2 deaths per 100,000 births. Since then, by 2013, it ballooned by 140% to 17.3 deaths per 100,000 births. This means that in 2016, more than 700 women died in the United States of pregnancy-related causes. The Maternal and Child Health Bureau estimates that over the past decade, maternal morbidity has increased by 75%. These changes in maternal mortality and morbidity indicate that something has changed with how the United States addresses maternal health. What has changed? One of the things that has happened is that we have become better at tracking maternal death. This is achieved in part through the addition of a pregnancy box on the standard U.S. death certificate in 2003. This has helped us collect better information about how a death may have been related to pregnancy. While this could explain some of the increase in numbers, it does not explain that maternal mortality has continued to rise since 2003. As the United States population leaves rural areas, healthcare providers also leave. For example, Gina Fine-Marin of Scientific American reports that in 1980, 45 of Alabama's 54 rural counties had hospitals that had departments dedicated to pregnant women. Now, only 16 of these counties do. She also shows that since 2010, 80 rural American hospitals have closed. This makes it so that rural women have a harder time making it to hospitals for checkup visits and might not even make it to a hospital to give birth, sometimes giving birth on the side of the road. Fine-Marin notes that the maternal mortality rate in metropolitan areas is 18.2 per 100,000 births. In rural areas, it is 29.4 deaths per 100,000 births. Unlike the poorest countries where maternal death occurs from events directly caused by pregnancy, like sepsis and hemorrhage, maternal death in the United States is becoming increasingly linked to overall worsening health. As conditions like obesity, diabetes, and hypertension rise, the maternal deaths related to these conditions rise. These ailments put a strain on the body. Pregnancy can be enough to push this strain to death. The opioid epidemic even affects maternal health in the United States. Use of opiates not only adds a risk of overdose, but it makes the woman generally less healthy and able to deal with pregnancy. Furthermore, severe opiate addiction makes it so that a woman might not go to a hospital for all of the treatment she requires during pregnancy. Another element of the rising maternal death rate is the reproductive choices American women make. When a woman ages, a pregnancy becomes riskier for her and the baby. As women in America choose to have babies later in life, they may inadvertently be putting themselves at higher risk. Furthermore, the high rate of voluntary C-sections in the United States makes pregnancies riskier. One of the things that can result from C-section is a condition called placenta accretia, where the placenta sticks to the uterus and may cause it to tear during birth. In the 1950s, this occurred about once per 30,000 deliveries in the U.S. Now it occurs about once per every 500 births. This change shows how the rising rate of C-sections made pregnancy more dangerous. One of the most startling facts of maternal mortality in the United States is the severe inequality hidden in these numbers. Black women are 243% more likely to die from pregnancy-related causes than white women. This chart shows how different maternal care is for Black and white women. In fact, this difference is one of the biggest racial health disparities between women in the United States. According to Renee Montagne and Nina Martin at ProPublica, Black women are 22% more likely to die of heart disease, 71% more likely to die of cervical cancer, but 243% more likely to die of pregnancy-related causes. What could be causing this difference? Black women are more likely to be uninsured than white women. A lack of insurance can mean that women might not be able to treat conditions that could make pregnancy more dangerous. It might also mean that they have less access to birth control, which could be useful in preventing a risky pregnancy. While Medicaid covers pregnant women without insurance, coverage usually ends within 60 days after pregnancy and only covers the very poor. When coverage ends, monitoring of things like heart conditions exacerbated by pregnancy also ends. This puts women at higher risk of death. Because Black women are more likely to have conditions like obesity, diabetes, and high blood pressure, their pregnancies tend to be more dangerous. These differences in health are linked to factors of inequality like health insurance, food deserts, quality of healthcare, and more. Researchers examining the role a hospital plays in maternal mortality and morbidity have found that high Black serving hospitals have much higher rates of complication than low Black serving hospitals. For example, Black women had a 67% higher rate of severe complication at the high Black serving hospitals than the low ones. This shows that the hospitals that serve large Black populations might not be as well equipped to deliver babies without problems. These researchers also noted that 75% of Black deliveries were performed at only 25% of hospitals in America. Improvement in care at these hospitals would likely help mitigate inequality in maternal health. As with many other issues in inequality, racism plays a role. Arlene Geronimus, a professor at University of Michigan Public School of Health, developed the term weathering to describe how day-to-day racism can wear down the health of Black Americans. The constant fight and stress that comes from confronting racism in daily interactions likely contributes to the overall poorer health of Black Americans. This poorer health makes Black women less likely to have pregnancy without complication. Furthermore, Black women must also fight the less overt cousin of racism, implicit bias, while receiving care during pregnancy and birth. Journalists Nina Martin and Renee Montagne note that many Black women report being perceived as poor, uneducated, uninsured, and an adversary, not a partner by their healthcare provider. This implicit bias means that Black Americans don't receive as much treatment for their pain as their white counterparts and suffer other inequalities in healthcare. Implicit bias in healthcare is an important issue of inequality in the United States, and its consequences are apparent in the differences in maternal mortality. The factors behind rising maternal mortality may make it seem like the rise is irreversible. However, the actions of Texas and California show that even a state government can do a lot to affect maternal care. This chart shows the staggering difference between maternal mortality between America's two most populous states. As you can see, Texas has risen significantly between 2010 and 2015, while California's rate has dropped. These changes can be explained by the actions each state has taken to address women's health. Between 2000 and 2006, the maternal mortality rate in California more than doubled. To address this, the California Maternal Quality Care Collaborative was founded in 2006. Their strategy involves addressing the most preventable causes of maternal death by partnering with hospitals to establish clear guidelines and strategies for treatment. Most of the hospitals in California have joined this program. An example of one of the things CMQCC implemented is a hemorrhage protocol to quickly treat the bleeding that can lead to death. They created hemorrhage carts, similar to the crash carts that are used in every hospital to treat heart failure. These hemorrhage carts show that California hospitals now take maternal death as seriously as a heart attack. Hospitals that joined CMQCC saw a 21% reduction in hemorrhage-related complications, while California hospitals that weren't in the program only saw a 1% reduction. They also reduced C-section rate in the state. Although the effects from this won't be seen immediately, it'll make later deliveries much safer. Though they have made a lot of progress in maternal death, doctors involved in CMQCC admit the problems of racial inequality and rising chronic conditions are challenging to address and still need improvement in the state. Texas, on the other hand, seems to have taken the opposite approach. In the state's continual attempts to curb abortion, they seem to have weakened women's health care. In 2011, they cut $73.6 million from the state's family planning budget. This meant that women had less access to centers that could provide birth control or abortions that would prevent risky pregnancy, and they had less access to services that could improve their health. In 2013, Texas passed House Bill 2. This limited abortion after 20 weeks, required abortion centers to make changes to their facilities, and required abortion providers to have admitting privileges to nearby hospitals. Though these regulations were framed as promoting women's health, they resulted in a disruptive drop in the number of abortion-providing clinics. The important thing about these clinics is that they did more than provide abortion. They also provided care to women without access to regular health services. House Bill 2 was overturned by the Supreme Court in 2016, but many of the closed clinics have not reopened. Furthermore, the Texas state government has opted not to adopt the Medicaid expansion that would help cover the very poor in their state. These factors and many more have resulted in an ever-increasing rate of maternal death in the state. The actions of these states illustrate the role that government can play in preventing maternal death. Pregnancy and childbirth-related death in the United States only results in about 700 to 800 deaths per year. Though these numbers appear small, they are an indication of how we care for pregnant women and are a reflection of the health of our country. The rising rate of maternal death shows that the United States is failing to sufficiently protect pregnant women. There isn't a single cause of maternal death. Factors like the woman's health before pregnancy, the care she received before, during, and after pregnancy, the quality of hospital she gave birth at, her level of health insurance coverage, her race, and even the state she gave birth in can affect the probability that she will suffer death or complications. Importantly, all of these factors are linked. To address rising maternal death, attention must be paid to each of these. The inequality between Black and white maternal outcomes is another reason why this issue is so important. Though this is somewhat explained by the poorer health of Black women, the disparities in health coverage, and implicit bias are all linked to the United States' seemingly intractable problem of inequality and racism. The differences in maternal mortality between California and Texas show how a state can make a deliberate change to affect this problem. The question is whether a state or our country will place a high enough value on the women at risk of dying to make these changes. That is my presentation, and here is a look at my works cited.